A lot of the stories that we're told today really go back to our maternal health crisis. So with that, we talk about, and you'll hear me talk about over and again, denial, delay, and dismissiveness. Stop, look, and listen. These are ways that we can, at least at the hospital level and at the patient level, at the physician level, try to improve our quality and care. And we've spoken today about the common themes that we've seen occur in the maternal health crisis. So with that, I'd like to sort of just move forward and just talk about the cardiovascular components of it. And as we work our way through that, we're going to talk about some of the opportunities that we have at the local and state and national levels to drive care and safety and quality in maternal health, and particularly obviously in cardiovascular, which we were able to see a reduction of close to 50%, if not more, in preventable mortality, but also the morbidities that we see and how we're tracked on that. So we know that death from cardiovascular disease represents anywhere from really 26 to probably 50+% of the pregnancy-related deaths. And obviously, as we've seen in our lifetime and in obstetrics, we're seeing the ever-growing crisis of obesity and hypertension and comorbidities. We're seeing the great work that Dr. Franklin's doing and having our adult congenital heart program. We're seeing those children survive to pregnancy. We're seeing assisted technology. We're seeing the additional components of our cancer, long-term survivors of childhood cancers, and the cardiotoxic events of their medications. They're surviving and going on to becoming pregnant. How do we manage that as a collaborative group and team is so important as we move forward. So these are just some of the goals and objectives, really just to describe the background of cardiovascular health, review some of the recommendations. And unlike many of the other processes that we have in obstetrics now that we've strived for, the cardiovascular process has not been well defined. We don't have that similar decision-making tools. And thankfully to our work that we're doing through AIM, the Alliance of Innovation in Maternal Health, through the work through ACOG and collaborative team members, we're able to start to engage and use multidisciplinary teams to come together. And whether that's cardiology, that's anesthesia, whether that's our neonatal teams, all to collaborate together and work together both from maternal fetal medicine and then the general obstetrician to drive and strive to improve maternal care and outcomes. So I have no disclosures. And I always like to start off my talks really talking about this overview from the World Health Organization. Mothers, the newborn, and children represent the well-being of society and the potential for their future. Their healthcare needs cannot be left unmet without harming the whole society. And that really goes back to that maternal-child dyad, and I really will go back to the maternal-child family triad component of it. So the World Health Organization has really helped frame that for me as we move forward. And we know that the cardiovascular is one of the most leading causes of maternal deaths in the United States, but we also know we deal with obstetrical hemorrhage. We also deal with deep vein thrombosis and prophylaxis. But if you start to look at it, you'll see that cardiovascular as the largest component of it and is continuing to rise. So some of the current state and background. Again, 40 to 50 to 60%, depending on what we're talking about. We're talking 90% for obstetrical hemorrhage. Our maternal deaths have been potentially preventable. Again, as we move forward, I think looking at vital signs, stop, look, and listen. Listen to that patient. That's been a recurring theme as we've talked about. How we have to do that, utilize that in terms of subjective versus objective data is so important as we move forward. And again, realizing that our obstetrical populations are our most vulnerable. Adding to that, the racial and geographic inequities. We've talked about rural medicine. We've talked about telehealth and opportunities. We also look at the systemic biases and the structural racism. I think overlying this whole component also is the social determinants of health. And we deal with healthcare silos, we deal with prenatal care, we deal with hospital care, and then there's that postpartum component, that fourth trimester, which can extend up to 1 full year. But we have the overlying role of the social determinants of health. And again, when you start to look at it, unfortunately, women now, when you start to look at it, are 50% more likely to die than their mothers who gave birth to them a generation ago. And that's even obviously worse, as we've talked about, for BIPAC, for Black, Indigenous, and people of color. So failure to rescue, I think, is a lot of it. And when we start to look at it at the hospital-based system, this is what we talk about. A good friend of mine discussed Dave LaGrue out of California, denial and delay. And I added the third D, dismissiveness. So again, the 3 Ds. Women are dying because they're not receiving early, effective, and aggressive life-saving therapy. We'll go about what AIM has done and what the California Maternal Quality Care Collaborative has done to improve those outcomes. But overriding this is we still see the disparities that are there, that racial and ethnic disparities that consist and persist in our healthcare systems. And this just highlights the similar data that a lot of our other colleagues have talked about. Again, this is from up to 2016, and I'll tell you some of these numbers actually in the New York metropolitan area are even higher for African American women based on their zip code and geographic locations. But again, this is quite disparaging. This was a slide from the CDC, again, going over the racial and ethnic disparities that we see in pregnancy. We talked about Serena Williams, and if you look at this next slide, again, I think highlights that component. A college graduate or higher, someone of socioeconomic status, has a higher risk of dying than someone who has less than a high school education and is white. Again, this is a recurring theme that we consistently see. The story that Dr. Waters spoke about, we're going to talk about with another colleague of mine who I actually know and have become quite friendly with, and his wife had passed. We all talk about the different types of inequalities that we talk about, and I like this slide to sort of, again, to frame that health equity component and optimization of care. We talk about equality, equity, and we talk about justice, and hopefully closing that gap as we talked about today. And that gap continues to widen, and that's the concern. The gap continues to widen, and yet it remains flat in white Caucasian women, but in African American it continues to climb. And this was a recent article that came out of the Green Journal back in May of 2021, looking at maternal mortality. Again, the tip of the iceberg. We still have severe maternal morbidities and near misses, which are, again, we're over 100 times that risk. But again, looking at cardiovascular component, 50% of these are really related to cardiovascular disease in pregnancy. And when we look at it in the larger frame across the entire world, the World Health Organization put out their global maternal health crisis. We're looking at the United States as being one of 3 countries in the world where our maternal mortality is rising. We are next to Afghanistan and South Sudan. That other slide that we posted today earlier really illustrates what other countries in low and middle income and developed countries we're equated to. And that's really a very disheartening theme. This is a report from the MMRC. I'm co-chair of the Arizona Maternal Mortality Review Committee, and this is one of the recent updates that we have from 9 of the MMRCs that really talks about our healthcare crisis and what we can use to prevent and eliminate maternal deaths at the both local and the state and both at the national level. And again, the work that we're doing for a review of action. I like this pyramid, unfortunately. I'd like to see it as an inverted pyramid, but death, near misses, SMMs, which is what we're actually tracked with nationally, is the severe maternal mortalities. The morbidities requiring rehospitalizations, requiring emergency room visits, and we'll talk about some of the options that we actually have developed here to reduce maternal morbidity mortality through our Alert 42 system at St. Joe's. And we talked about this, again, how are the breakdown of where pregnancy maternal mortality occurs. 38%, it's about a third of that within the 42 days of delivery and obviously up to 1 full year. And the conditions that we talk about in cardiovascular and hemorrhage, they are preventable. And this was just some of the data that we have from Arizona. And while Arizona has done quite well, and probably in the middle of the country, we still have room for improvement, and we are still seeing increasing rises in the maternal mortality crisis, again, especially in rural areas and in our indigenous populations. And again, just going over some of the data that we actually have seen through Arizona. What are we seeing actually out in the community? This is really what we see in the newspaper, in the print, in the social media. Death by delivery. We talk about Black Mamas Matter, and Serena Williams and her stop, look, and listen, and lack of listening to her. And again, maternal mortality, while it occurs in 700 women, die in the United States a year. That's 2 deaths per day. That is unacceptable, when 50% of them are preventable, if not more. On one of the conferences I was just on in Belgium in the past 2 days, one of my colleagues talked about this, the 3 delay models. Recognition, and I think this goes back to patient-informed consent, patient decision-making, patient recognition of their healthcare crisis and the healthcare needs. The lack of the physician, the delay of physicians referring to higher levels of care, and then at the level of the hospital, the level of responsiveness. And we're going to talk about what AIM and the Alliance of Innovation in Maternal Health has been able to do to improve that. For Kira, for moms, Kira Johnson untragically lost her life after a routine elective repeat cesarean section. About 10 hours after her birth, Charles literally witnessed his wife pass away in front of him. Charles and I have become dear friends as we've talked on circuits and about maternal hemorrhage and maternal health crisis. And he didn't want to be that angry black man. There's not a dry eye when Charles talks in a room. And the impact that this had in a socioeconomic, well-privileged family that he just felt he didn't. And Kira said to him, he said time and time again, don't be that angry black man, as she's literally becoming hypotensive, tachycardic, and blood, and her urine had turned from yellow to bloody as she became further coagulopathic. Deadly deliveries is out there. These are all seen in many publications and social medias, and the slides that you see here on the bottom illustrate what we're dealing with in the maternal health crisis in the United States compared to other developed countries. Lost mothers, and how we can be able to now really make that impact. And the story of Charles and Kira is not one of the only stories, and a similar story can be told about Shalon Irving. And Shalon Irving was a master's PhD student who worked for the CDC, and her mom and her family have spoken to me at times and have told me about her story. And we do have a video that we could show later about the Shalon Irving story. But again, denial, delay, dismissiveness, the lack of accurate utilization of the data, the hypertensive crisis, and the lack of treatment until, unfortunately, she had the severe event and passed away from her hypertensive disorder in the postpartum period. Tara Hansen, again, another story, who died of peripheral sepsis, but again, that became that Stop, Look, and Listen campaign. We talk about 1, 2, 3, 4 Moms, which is Maternal Health Day, developed again to increase the awareness of the maternal health crisis that we see. So what are we doing? We're actually moving towards evidence-based practices. We really have not had that in obstetrics. We're looking at bundles of care. We're looking at standardized procedures and utilizing evidence-based medicine really to improve those healthcare outcomes. AIM looks at this, the Alliance for Innovation in Maternal Health. A few years ago, the American Congress of OBGYN joined forces with multiple healthcare other organizations, outlining and researchers and community organizations to implement standards of care into these bundles. The Alliance of Innovation in Maternal Health was able to drive both hypertension, obstetrical hemorrhage, deep vein thrombosis, safe prevention of primary cesarean sections. All of these have been driving our readiness, recognition, response, the 4 R's. And Elizabeth Howell, a friend of mine from Sinai, always spoke about the racial and ethnic disparities, and we've been able to really try to incorporate that and to become the 5 R's of readiness, recognition, response, reporting, and racial and ethnic disparities. And AIM now really looks at both at the local level, at both the hospitals, it looks at it both at the state level and obviously nationally, and really trying to drive the quality in care, looking at rapid data cycles and reevaluation of that data for each of those hospital systems to improve care and care outcomes on their units. And we talk about these bundles of care, very easy to implement, both in a low resource to both high resource, to a rural to an academic center, how you're best able to improve these outcomes. This is now one of the maternal AIM bundles for postpartum care basics. Other ones are similarly structured to implement the care and the care models for each of the hospital systems. The Joint Commission has adopted similar of these for hemorrhage and hypertension. So again, being able to utilize this to improve community care and community outcomes. And this is a reduction of the peripartum racial and ethnic disparity bundles. So what are some of our opportunities? Really looking to partner together, collaboration both at the level of AIM, both at the perinatal quality collaboratives, which are state-wide collaboratives to improve outcomes, and looking at the maternal mortality review committees, unfortunately, to improve care and care outcomes. Mary Dalton is a dear friend, and I take this to heart. One of the most important things a woman can do for herself is to ensure a happy pregnancy outcome is to choose a hospital that can manage your particular risk profile. And I think risk assessment is another part of this that we fail to operationalize. MEOWs and modified early obstetrical warning systems, again, improving subjective data, making them objectified to call the care team to come to that bedside. ACOG came out with updating postpartum care, another opportunity to improve outcomes. And as we start to talk about the fourth trimester project is based out of UNC, really looking at the ability to start to operationalize for patient education. How do we improve those outcomes to prevent those mortalities, morbidities, and even the peripartum state? A1, Save Your Life, which is a tremendous campaign of collaboration and education to highlight those signs and symptoms of postpartum birth warning signs. Magnets, tear-off sheets. They're actually in probably about 15 to 20 languages now, so you can be able to utilize that for your care and care models. This was a recent campaign that just came out from the CDC which is our Hear Her concerns. Again, little vignettes to improve the clinical care models and to improve and start to hear that stop, look, and listen concept that we talk about. I don't think any slide of ours would ever do justice to what the work that California has done. Elliot Main and his team at the California Maternal Quality Care Collaborative, they're our young adult, and many of us are otherwise are very early in our gestations and our perinatal quality collaboratives. But the work that Elliot and his team has done has shown here in the blue specifically with each of the implementation of their California collaborative bundles of care have driven maternal health crisis down from where we are in the rest of the United States. This speaks volumes for standardization of evidence-based practices. And people said to me, well, that's California. They have tort reform. They're all Kaiser Permanente. They have to listen to them. That's not true. Illinois has done it. Florida has done it. We can do it. And that's what we're here now to strive for. But the one thing that Elliot wrestles with, and we just talked about this yesterday on their new bundle for hypertensive disorders in pregnancy, is the racial and ethnic disparities that they're still struggling with. That's where they're having the issues. They've been able to drive down that maternal mortality, but their racial and ethnic disparity component of it still continues to lag. So just to bring you up to date, this actually toolkit just got revitalized. This is the cardiovascular one that I'm just going to present real quickly, but the hypertensive disorders in pregnancy was just re-released yesterday. It should be forthcoming to the on their website within the next week, hopefully. And it was very exciting to start to talk about some of the little changes that we've been able to make in their care models. But this is one, again, the quality toolkits really to improve maternal health care that they used in California. And again, looking at 257 deaths in these 4 years, represented close to 2.7 million births. And looking at this, where we're having our risks are, again, cardiovascular, cardiomyopathy, cerebral vascular abstinence. Those are the key components, preeclampsia and eclampsia. And again, as we start to look at it, the risk of both cardiomyopathy and cardiovascular, these are preventable maternal mortalities, which again speaks highly for our care models to engage and collaborate together. And again, their data now shows 2.4 deaths per 100,000 now related to cardiovascular as they continue to drive down that care models. So again, going back to, again, some of the education, again, such an important part to engage patients and families in their care models. So again, looking at the signs and symptoms, we've done something similar. This is the California collaboratives. And I have to thank Dr. Bond and our team that we work together to get this heart health passport out to our patients also. Really is an educational material to give to our patients in the hospital, in the offices, to alert them to their signs and symptoms of cardiovascular disease, and again, to continue that discussion. Some of the other opportunities that we have, we've redeveloped a triage. To me is a process. OB triage, again, is a process. We now have a perinatal assessment and treatment area, utilizing the maternal fetal triage index. So again, looking at data similar to the emergency room, similar to our colleagues in the emergency trauma department, and engaging them in looking at the emergency severity index and how best to triage those patients to best assess them and get them treated in the peripartum period, and we're going to talk about in the postpartum period. And this is, again, the maternal fetal triage index, and this is the opportunity to, be able to call these patients in a timely fashion, either immediately within 15 minutes, 30 minutes, an hour, to have them assessed. This is our PDSA that we're working on to improve that, to really look at how our perinatal assessment area can best function and just start to track those outcomes. And I'm very happy about another project that we're working on called an Alert 42. So while we talked about death within 1 year in the postpartum period, within that first 42 days of birth and childbirth is the concern that we also have. And I got a lot of pushback from our residents when we rolled this out. You know, why do we need to go to the emergency room to see a patient who delivered, who's got a hypertension? She should come up to labor and delivery. That's what we've been doing for years, Dr. Rubenstein. That's not how we do it here. I will tell you, when we looked at our PDSA and we looked at our data, in the first 6 weeks when we looked at it, we looked at 28 patients that actually came into the, quote, the wrong door, right? They came into the emergency trauma department. They were postpartum. They were immediately called out and escalated their care. They got their hypertensive meds within the time fashion of less than 30 minutes. Magnesium sulfate was started immediately after the hypertensive meds were in concurrently. And they were then taken by our care team, had mobilized and seen and evaluated that patient and moved her back up to labor and delivery, where she can continue her care with our labor and delivery or critical care teams, and or needing additional interventions. So this was, again, a collaborative partnership with the emergency room, and it really has shown to be a valid opportunity to improve care and care outcomes. Initially, it was mostly thought of as hypertension, but you can expand that model, and which is what we're planning to do, is really for any potential cardiomyopathy, hypertensive crisis event, postpartum depression, obstetrical hemorrhage. All those things are all important parts of this to improve care and care outcomes. Some of the data and some of the education and noted to share that we developed for the teams, again, to educate them to the Alert 42 model. Now my residents have come back to me and said, thank you for doing this, because those 28 plus patients now almost on a monthly basis are getting expedited care in care model, whereas otherwise that 160 over 100 would have been left in the back in the emergency room, and it would have been a delay in care. Again, moving forward on some of the postpartum presentations that we've been able to do and improve the outcomes and just highlight that education. I want to thank everyone again for allowing me to discuss about the maternal health crisis and our team today, so thank you.